Hello, my topic is trigeminal nerve structure, functions, and the topical diagnosis in case of any of its problems. As we all know, its anatomy. I will not talk much about it in detail, but we all know that it starts in Meckel's cave. The ganglion known as Gasserian ganglion is present in Meckel's cave, and it is responsible for giving out three divisions. Two of them are purely sensational, and the last one is mixed. It contains both motor and sensory fibers, and they go like ophthalmic, mandibular, and maxillary. The first two, as I said, are sensory, and they go to the orbit, the eye orbit, and they give branches, various branches. I will now explain them. And the third one, it gives off uh, branches, motor branches to the muscles of mastication, and that is the only uh, motor part of this nerve. Now for the pathway. Um, the pathway of this nerve is similar to that of the sensory pathways we just learned, and they also decussate together with 5, 7, 9, and 10th cranial nerves from the main trigeminal sensory nucleus. So a problem in this nucleus or anywhere above it causes contralateral weakness. But if the problem is below it, we can have ipsilateral weakness of the face, but contralateral weakness of the body, because all cranial nerves supply ipsilateral areas of the face, but contralateral areas of the body. Functions, as I said, the ophthalmic division gives sensation to forehead, upper lid, upper half of cornea. The maxillary division, it gives cheek, lower lid, lower half of cornea, etc. The mandibular, it has similar sensory divisions, but the motor divisions are for the mastication muscles, masseter pterygoids, digastric, and mylohyoid. And they're also involved in reflexes, just corneal reflex or jaw jerk reflex. Jaw jerk reflex is when you ask the patient to open his mouth and then you slightly jerk on his chin. If the mouth closes, that means the maxillary division, the mandibular division is working correct. Now, for the disorders, they can be due to lesions in the face, skull base, or cavernous sinuses. As we know, only two divisions pass through the cavernous sinuses, ophthalmic and the maxillary. The mandibular division does not cross. So in this lesion, only sensation will be affected. Or the trigeminal pathways in the dorsolateral brainstem. As I said, the pathways are similar to the sensory pathways we just learned, and they arise together with the 9th, 10th, and 11th cranial nerve. So any disorder in the trigeminal pathway also affects the other cranial nerves. The ventral posterior medial nucleus of thalamus. This is the place where the third order neuron arises. So any problem here will basically affect all of the function of trigeminal nerve. The lateral post central gyrus, this is the place where the third order neuron end. So any problem here will again affect the whole nerve and its sensation. The subcortical matter connecting VPM and somatosensory cortex, the same as above. Since the face and hand have the most cortical sensory representation, a common pattern of numbness or cortical, subcortical, and small thalamic lesions is contralateral face and hand numbness, chiro-oval pattern. For example, like I just said, the fibers of the trigeminal decussate together with the other cranial nerves. And in the cortex, we have the map which shows that face and hand are most lateral and most medial are leg. So any lesion above the point of decussation will cause contralateral numbness, especially in the face and hand. Facial numbness due to an isolated trigeminal nerve lesion can be caused by malignancy, skull-based tumors, cerebellopontine angle tumor, or leptomeningeal metastasis. Inflammatory disease such as Sjogren's syndrome, in which the nerves are inflamed, and the most common symptom is dry mouth, sarcoidosis, spread of head and neck cancers along the trigeminal nerves, and it's most commonly caused by squamous cell cancer of or skin of the skin or the face. Dental pathology, any dental problems you have because there are alveolar nerves that arise from the mandibular divisions. Numb chin sign. Numbness of the chin should raise concern for metastatic malignancy affecting the mandibular. The most common metastasis is from the apex of the lung and spreads very easily even though the lung is far away. Trigeminal neuralgia. This is a very common symptom. It has brief lightning-like paroxysms on the face, very painful. These may be spontaneous or may be triggered by contacting the face. It's most commonly unilateral on one side and affects the lower face V2 or V3 region, that is the mandibular and maxillary region. The condition may be idiopathic or it can be caused by multiple sclerosis, a compressive vascular loop, or many other etiologies as we know. Lesions affecting the motor nucleus. The motor nucleus of cranial nerve 5 is medial to the main sensory nucleus in the dorsal pons. Unlike the common symptoms, jaw weakness due to a lesion in the nervous system is uncommon. So it's always mostly sensory, and isolated motor weakness is very uncommon. Yeah, that's about all. And now this is the topical diagnosis. This is the topical diagnosis of the trigeminal nerve. As we can see, the first branch of thalamic zone extends from the scalp to the nose. The maxillary zone, the whole part of maxilla, and the mandibular zone, again from the scalp till the lower jaw. This is used to diagnose which part of the nerve is affected if and when there is sensation loss. Thank you.